Hello, it's Dmitry again. This is the third video I'll be uploading today, and I suspect I might make some more later on today as well. But we're going back again to Blueprints Psychiatry, now in Chapter 15 for Miscellaneous Medications. Now, this is the 5th edition of the textbook. There's a 6th edition out there as well, which has some updated material and some differences in the organization of chapters and material, so just bear that in mind. But nevertheless, let's get into it. Chapter 15, Miscellaneous Medications. This chapter includes medications that are used to treat substance dependence, attention deficit hyperactivity disorder, ADHD, and Alzheimer's disease, as well as medicines commonly used in psychiatric practice that do not fall into the conventional categories of psychotherapeutic drugs. Many medications used in general medical practice have side effects such as sedation, stimulation, or anxiolysis. These side effects are often exploited in psychiatry to target specific symptoms, that is to say, insomnia or anergia. Other drugs, such as psychostimulants, have precise indications for psychiatric usage. Table 15.1 shows common indications of psychostimulants, anticholinergics, beta blockers, thyroid hormones, and other drugs. Many more medications than are discussed here are included in the psychiatric armamentarium. Anticholinergics. Medications with anticholinergic activity are commonly used in psychiatry to treat or provide prophylaxis for some types of neuroleptic-induced movement disorders. Anticholinergics are generally used as first-line agents in the treatment of neuroleptic-induced Parkinsonism and for acute dystonia. They may also have some utility in treating akathisia, but are best tried after beta blockers and lorazepam. The most commonly used anticholinergics are benztropine and trihexyphenidyl. In addition, diphenhydramine and antihistamine that also possess anticholinergic properties is frequently used to treat neuroleptic-induced movement disorders and to provide non-specific sedation. These medications are central nervous system muscarinic antagonists. Side effects of anticholinergics caused by peripheral anticholinergic action include blurry vision as a result of cycloplegia, constipation, and urinary retention. Their principal central side effects are sedation and delirium. Anticholinergic toxicity is a major cause of delirium, especially in individuals with dementia and human immunodeficiency virus encephalopathy. So it can cause delirium, and it's going to be worse in particular conditions like dementia, people with HIV encephalopathy, that kind of thing. Beta blockers. Beta blockers are used widely in general medicine. In psychiatry, they have a few specific uses. Beta blockers likely alter the behavior and mood states by altering both central and peripheral catecholamine function. For example, in anxiety, they may diminish central arousal. Peripherally, they may reduce tachycardia, tremor, sweating, and hyperventilation. Common side effects of beta blockers include bradycardia, hypotension, asthma exacerbation, and mass hypoglycemia in diabetics. Beta blockers may also produce depression-like syndromes characterized by fatigue and depressed mood. And so they just kind of go directly into that. But we're going to go now particularly into the section about medications used to treat ADHD. So what about that? Atomexetine. So atomexetine, also called Strattera, is a selective norepinephrine reuptake inhibitor, medicine approved for treating attention deficit disorder. Similar medications are approved in other countries for treating depression, and although atomexetine is used off-label in the United States for treating depression, its efficacy is unknown. Like other medications that have monoamine reuptake as a primary mechanism of action, that is to say, for example, selective serotonin reuptake inhibitors, or SSRIs, atomexetine has been associated with an increased risk of suicide in children and adolescents that requires careful monitoring, especially during initiation or tapering of the therapy. I want to see if I go in. Okay, we go to clonidine immediately after that, so let's just read the table out for you right now. Table 15.1, psychiatric uses of miscellaneous medications. So medication class, major psychiatric uses. So psychostimulants is their first class. What is it used for? Treatment of attention deficit disorder, treatment of depression in elderly or medically ill, treatment of narcolepsy, augmentation of antidepressants in refractory depression. What about anticholinergics? Well, anticholinergics are used for treatment of neuroleptic-induced Parkinsonism, and they're used for neuroleptic-induced dystonia. What about beta blockers? They're used to treat impulsivity, performance anxiety, akathisia, and lithium-induced tremor. What about disulfiram? It's used to prevent alcohol ingestion, basically because you have this really nasty reaction when you drink alcohol if you're taking disulfiram. It's called a disulfiram reaction. Opioid antagonist, treatment of alcoholism. Glutamate modulators are used to treat alcoholism. Opioid partial agonists are used to treat opiate dependence. Clonidine is used to treat impulsivity, Tourette syndrome, opiate withdrawal, and attention deficit disorder. Acetylcholinesterase inhibitors are used to treat mild to moderate memory loss and Alzheimer's disease. NMDA antagonists, that would be N-methyl D-aspartate antagonist, treatment of moderate to severe memory loss and Alzheimer's disease. Thyroid hormones, you would have that for augmentation of antidepressants in refractory depression. Okay, so let's go back into this now. Clonidine. Clonidine is a CNS alpha-2 adrenoreceptor agonist. The alpha-2 adrenoreceptor is a presynaptic autoreceptor that inhibits the release of CNS norepinephrine. The primary use of the clonidine in medicine is as an antihypertensive. In psychiatry, clonidine has been variously used. It is effective in decreasing autonomic symptoms associated with opiate withdrawal in the treatment of ADHD and Tourette syndrome, and may be useful for impulsiveness and other forms of behavioral discontrol. Side effects include sedation, dizziness, and hypotension. Psychostimulants. Psychostimulants are used in psychiatry to treat attention deficit disorder, narcolepsy, and some forms of depression. Commonly used psychostimulants are dextroamphetamine or dexedrine, methylphenidate, Ritalin, Adderall, a mixture of amphetamines, and Pemilon or Cylart. The mechanism of action of these medications appear to occur through their alterations of CNS monoamine function. Their primary mechanism of action is thought to be facilitating endogenous neurotransmitter release rather than acting as a direct agonist. Psychostimulants have the liabilities of inducing tolerance and psychological dependence, which may lead to abuse. The side effects of these medications are due to largely their sympathomimetic actions and include tachycardia, insomnia, anxiety, hypertension, and diaphoresis, so sweating. Weight loss may be an unwanted side effect in young children, but a desirable one in overweight adults. Okay, what about medications used to treat substance dependence? Well, we have naltrexone, which is also called Revia, is a mu opioid antagonist that is used to prevent alcohol relapse and to lessen the severity of a relapse in individuals with alcohol dependence. Naltrexone treatment is initiated once a patient has been detoxified from alcohol. For individuals co-abusing opiates or who are receiving opiates for medical reasons, naltrexone treatment should not be initiated until at least 1 week after their last opiate exposure. An opiate antagonist can precipitate severe opiate withdrawal if given to opiate-dependent persons. Naltrexone reduces alcohol craving, reduces the probability of an alcohol relapse, and reduces the severity of a relapse when it occurs. Naltrexone, like all treatments for alcohol dependence, works best when combined with psychosocial interventions. What about acamprosate? Acamprosate, or also called Camprol, which is the brand name, is the most recently approved medication used in the treatment of alcohol dependence. Again, this book was written a while ago, this edition, so it's probably no longer the case that it's the most recent. Nevertheless, acamprosate is indicated for maintaining abstinence in previously alcohol-dependent subjects who are abstinent at treatment initiation. Acamprosate may work via numerous mechanisms, including a modulator of glutamate function. This medication seems to reduce the craving and urge to drink in patients recently withdrawn from alcohol and helps maintain abstinence and make relapse less severe. Acamprosate should be combined with psychosocial interventions in the treatment of alcoholism. Bear in mind the value and utility of psychosocial intervention. What about disulfiram, also called antabuse? It is used to prevent alcohol ingestion through the fear of the consequences of ingesting alcohol while taking disulfiram, table 15.1. Disulfiram blocks the oxidation of acetaldehyde, a step in the metabolism of alcohol. The buildup of acetaldehyde produces a toxic reaction, making an individual who ingests alcohol while taking disulfiram severely ill within 5 to 10 minutes. Symptoms include flushing, headache, sweating, dry mouth, nausea, vomiting, and dizziness. In more severe reactions, chest pain, shortness of breath, hypotension, and confusion occur. Fatal reactions, although rare, can occur. Disulfiram use should be restricted to carefully selected patients who are highly motivated and who fully understand the consequences of drinking alcohol while taking disulfiram. Side effects in the absence of alcohol ingestion include hepatitis, optic neuritis, and impotence. So even if you're not taking alcohol, it can still cause things like hepatitis, optic neuritis, and impotence. So, it is there is some people who are not big fans of using disulfiram because of the fact that it's really just a psychological thing. It's basically training your brain to not consume alcohol because now you're going to associate alcohol consumption with very bad negative effects while not really having any sort of meaningful positive alluring effects anymore, right? It just makes it very, very unsettling. You drink alcohol and all of a sudden now you're, flushing, headache, sweating. It's terrible, right? It's awful. And that's the whole point. The idea is to make alcohol not enjoyable for you to consume. And so you would stop doing it if you have an alcohol problem. That's the idea. Buprenorphine. Buprenorphine is used for the treatment of opiate addiction. As a partial opioid agonist, buprenorphine has a role in opiate detoxification. Unlike methadone, maintenance treatment for opiate dependence, which can only be used in specialized methadone treatment centers, oral buprenorphine or Subutex, or a formulation containing buprenorphine and naloxone, which is called Suboxone, are available for use in outpatient office-based practices. The parental form of buprenorphine, called Buprenex, a lot of different names here. Buprenex now, okay. So Subutex is the oral buprenorphine. Buprenex is the parenteral form, or the parental form. And Suboxone is when it's combined with naloxone. But anyway, Buprenex is used intramuscularly for treating symptoms of opiate withdrawal in some circumstances. Because buprenorphine is a partial opioid agonist, it has a greater safety margin with regard to side effects such as respiratory depression. Mixing buprenorphine with naloxone is designed to prevent diversion of the buprenorphine tablets for recreational intravenous injection. If taken as an oral sublingual preparation as prescribed, the naloxone, an opiate antagonist in the medication, has a poor absorption and therefore does not interfere with the desired therapeutic effect of buprenorphine. If the oral pill is crushed or otherwise converted to an injectable form, however, the naloxone component as the mu-opioid antagonist is effective, blocking naloxone's effects as a partial agonist at the mu-opioid receptor. So basically, they're putting the naloxone in there to ensure that the potential abuse capacity for it is not going to happen, even if the therapy, despite the therapeutic quality of it being preserved. Makes sense? That's the idea. Okay. Let's see. Okay, this is interesting. Next section: medications used to treat insomnia. Most benzodiazepines, see Chapter 14, have hypnotic or sleep-inducing properties, including decreasing sleep onset latency, time to go to sleep, decreasing the number of and duration of nocturnal awakenings, and increasing the overall sleep time. Tolerance to these medications develops rapidly, and sleep architecture during their use is abnormal. There are also non-benzodiazepine hypnotics like zolpidem, Ambien, Ambien CR, Zaloplan, Sonata, and esoplaclone or Lonesta. Yeah, these are basically actually acting on the same receptor site at the same location that the benzos would act on, but they are not addictive. And they are technically not benzos. I think they're chemically different as far as I'm aware. They just act at the same site. These drugs are gamma-aminobutyric acid receptor modulators. Naturally occurring melatonin in a pill form is also used to induce sleep, and that's acting at a completely different receptor, by the way. Melatonin and these sort of melatonin drugs that you could use, I think, I'll make sure that I'm not saying this incorrectly, but I think Ramelteon, which is a prescription melatonin receptor agonist. Yeah, so that's an example of another thing that can help you go to sleep, but it has nothing to do with the benzodiazepine receptor at all. Oh, they say, I'm sorry, they should say it right here. Okay. Melatonin and in pill form is also used to induce sleep. Okay, a new medication called Ramelteon. Okay, so I should read, maybe one sentence ahead. Rosaram is believed to work by binding to the melatonin receptors in the suprachiasmatic nucleus. The gamma-aminobutyric acid, i.e. GABA modulator sleep aids, have been associated with the formation of tolerance and dependence. Yes, but typically the ones that we're talking about, the non-benzo types, that act at the same receptor of benzos, that is to say, the azopiclone, zolpidem, zaleplon, they typically are not associated with this sort of addiction that you can get with the benzos. Ramelteon may not have this problem, but further experience and studies are needed to be certain. Some sedating tricyclic antidepressants like amitriptyline and trazodone have been used to treat insomnia. They do not appear to promote tolerance and dependence, but may not promote physiologically normal sleep. So, be aware of that as well. And the thing is, I hear statements like this, they make, it may not, we're not sure, blah, 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 but I'm trying to figure out, because it's been a while since they published this edition, so I'm not sure if that's still true. Does induce normal sleep. Physiologically normal sleep. Okay, so according to Google.com, the Google AI, it says here, no, neither tricyclic antidepressants like amitriptyline nor trazodone induce physiologically normal sleep. While both effectively act as sedatives to help patients fall asleep and stay asleep, they significantly alter the brain's natural sleep architecture, the natural progression of REM, rapid eye movement, and NREM, so non-REM sleep stages. So the answer is no, based on the current data, which some of that stuff I'm seeing here is even from 2026, so, and some from 2021. So this is stuff that was published after this edition was published. So based on the most recent data, the answer is it's not normal. Medications used to treat dementia, cognitive enhancers. A number of medications are available in the United States for the treatment of a cognitive dysfunction associated with Alzheimer's disease. Donepezil, or Aricept, rivastigmine, Exelon, galantamine, Remenil, and Tacrine, Cognex, are reversible inhibitors of an enzyme acetylcholinesterase and are used to enhance cognition in patients with mild to moderate dementia of the Alzheimer's type. So again, those names are rivastigmine, donepezil, galantamine, and Tacrine. I've heard about galantamine, rivastigmine, donepezil. I've heard less about Tacrine. Maybe that's out of favor. I'm not quite sure. But definitely remember some of these names, though. The brand names are not as relevant. The names you're going to see on the exams are going to be the standard name, not the brand name. Like the generic name, basically. Rivastigmine also inhibits butyrylcholinesterase, a property that may contribute greater efficacy to rivastigmine in later stages of Alzheimer's disease. Galantamine also has an activity at nicotinic cholinergic receptors that may be clinically significant. Some of the cognitive deficits in Alzheimer's disease results from loss of cholinergic neurons in the basal forebrain that project to the cerebral cortex and hippocampus, which results in a deficiency of the cholinergic neurotransmission, figure 15.1. By inhibiting the enzyme or enzymes that hydrolyze synaptic acetylcholine, these drugs are thought to raise synaptic concentrations of acetylcholine in the remaining cholinergic neurons. Initially, these drugs reduce cognitive impairment. However, this effect wanes with the progressive loss of cholinergic neurons. Common side effects include GI upset and other cholinomimetic effects, including bradycardia and increased gastric acid secretion. Tacrine can cause elevations in serum transaminases and severe hepatotoxicity and is therefore reserved for second-line treatment. And that might be the reason why I'm not as familiar with it, because maybe they just don't really use it as much. Acetylcholine system. So here's a little figure here called 15.1, figure 15.1. The cholinergic diffuse modulatory system arising from the basal forebrain and brain stem. And so we can see that little thing there with the hippocampus, or you could say this is the pontomesencephalo-tegmental complex. That's a mouthful. But yeah, the pontomesencephalo-tegmental complex is giving out these, what looks like some sort of signal going to the hippocampus, going to the basal nucleus of Meynert, going to the medial septal nuclei, going to the thalamus, going to the neocortex. Okay. Memantine, also called Namenda, which is the brand name, a new class of cognitive enhancers for Alzheimer's disease, is available. Memantine is an antagonist at the excitatory glutaminergic N-methyl diaspartate receptor, so the NMDA receptor. Memantine is approved for the treatment of moderate to severe dementia of Alzheimer's type. Antagonism of the NMDA receptor may help prevent glutamate-mediated excitotoxicity and help improve the function of neurons involved in some forms of memory, for example, in the hippocampus. Thyroid hormones. Thyroid hormones are used primarily in psychiatry to augment the effects of antidepressants. They may also be used as adjuncts in treating rapid cycling bipolar disorder. Although clinical hypothyroidism can mimic the symptoms of depression, some individuals without clinical hypothyroidism may respond to thyroid augmentation nevertheless. The theoretic basis for using a thyroid hormone lies in the finding of altered hypothalamic pituitary adrenal axis functioning in depressed individuals. Although there is debate as to their relative efficacy, both triiodothyronine and tetraiodothyronine cross the blood-brain barrier. The tetraiodothyronine has been shown to be of use in conjunction with lithium to improve clinical control of rapid cycling bipolar disorder. Side effects at low doses are minimal. When dosages result in over-replacement, symptoms of hyperthyroidism emerge. You just have to be kind of cautious about that. Okay, so here's the end of the chapter. It was kind of scattershot. It was all over the place, because it's miscellaneous, right? Anyway, here's the key points, though. A number of medications are available to treat Alzheimer's disease, ADHD, insomnia, and substance dependence. These drugs target brain chemistry believed to be related to the disorder's underlying pathophysiology. Medications that affect various neurotransmitters can be used to counteract the side effects of other psychotropic medications. And that is the end of our chapter on miscellaneous medications. That was chapter 15. Now, if I were you, you might want to read these chapters. You might want to read a different source if you want to, from a different textbook if you want to, on the same kinds of concepts. But you need to have a good kind of comprehensive overview or understanding, like in a logical way, of all the different kinds of drugs you would use in psychiatry. The benzodiazepines, the SSRIs, the SNRIs, the mood stabilizers, etc. So you can kind of figure out when they have a question. They ask you a question on the exams. They say, what could you use? You got to know what kind of class of drugs you want to use, and then based off the patient's profile, say I want to use this type of drug and not this kind of drug because I know this drug has certain kinds of contraindications which are relevant for this patient because maybe they have impaired liver function, maybe they have impaired kidney function, maybe they have a history of not being receptive to this kinds of drugs, whatever it might be. And you also need to know the side effects independent of any sort of contraindication. You might need to know, this drug causes delirium in certain circumstances, or this drug causes hypotension, or whatever it might be. So just the drugs are very, very important when we talk about medical exams. So always bear that in mind. But anyways, if you enjoyed the video, hopefully it was good use to you. Regardless if you enjoyed it or not, hopefully it was good use to you. Anyways, have a great rest of your day. Thank you, and goodbye.